and I'll be discussing how we rehabilitate the socket. So far we've talked about orbital implants and how to take care of the socket. But sometimes even though those two things are taken care of, we don't achieve perfect cosmesis. So how to take care of that is what I'll be talking about. I would like to thank my past institutes from where I learned and grew. We start with this picture. What do you think is wrong in this picture? I'm sure you know who he is. Any comments, please? You can shout out the answers, no problem.
Right upper.
Yes.
Road.
No upper, yes sir. So no eyebrows. So eyebrows make a difference no matter who you are. So we have to remember that in order to achieve perfect cosmesis, we should not only be looking at the ideal prosthesis, which looks normal, symmetrical or merges well, but also look beyond that. Look at the entire face, look at the eyebrows and things like that. So let us discuss two case examples where we can just have a short discussion on what all can be done when the patient walks into our clinic. This is a retinoblastoma socket. As you can see, he has had previous surgery. His eye is ill-fitting. The lids do not close. It's a grade 4 or 5 contracted socket. He's received radiotherapy. So he is, as Dr. Seema would say, a difficult socket. So what can we do for him? We've discussed so far that it is a contracted socket with prior surgery, surface and volume loss, and with prior irradiation. Dermis fat graft with mucous membrane with fornix formation sutures for sure. That is the standard protocol. But these patients often come back with recurrent contractures. So what else can we do beyond the socket? Well, we have started this thing and it is being presented in an innovation conference. It's autologous fat harvesting and storage. So at the time of the primary surgery, this work was initiated in Narayan Nethralaya with the help of Grow Lab. What we do is during the dermis fat graft, we manually harvest the fat, and if we have a support of any lab, we can cryopreserve it under sterile conditions. This fat stays like that for up to 1 year, and it has been proven in aesthetic literature where people use this as a natural filler for rejuvenation. And this fat then, after centrifugation, can be re-injected in a minimally invasive technique into the patient's socket in case of repeat contracture. Again, this is an ongoing project. It's not really, we are not out with the full results, but this is the hypothesis, and so far we've done like 4 cases on this. This is the immediate post-operative result. The patient is wearing a painted conformer. It's a clear plastic shell with the iris painted. So that again has a very positive psychological effect on the child and his family. And at the end of this exercise, we already have our plan B in hand. During the first surgery only, we have harvested some graft and we've stored it in the bank for the child. So later on, if he needs a bit of augmentation, we simply have to give minimally invasive injections instead of having to repeat the surgery. The stored fat also is known to have mesenchymal fibroblasts, which are stem cells, so that really helps in a positive way to deal with most of the contractions. Now coming to the ideal socket. So what according to you out of these two would be the ideal socket? Any comments? Is it the male on this side or is it this female? Which would you call the ideal socket? You can shout out the answers.
Female.
Female. I heard female. How many for the female? Ideal socket. Ideal exentration socket. Okay. So we'll go with the first answer of female. Now let us look at the ideal defect. When I started working with the prostology team, the anaplastologists and others, they said that the female was not the ideal defect, and this is the reason. When you look at this video carefully, generally we do lid sparing exentration and we suture the upper and lower lid and give a very neat looking socket. But when we look at this, when you ask her to close the eyes, you see there is motility over there, and also the eyebrow is pulled down because of the orbicularis action. Now practically when we try to take an impression of this socket, it's a mobile socket, so you do not get an accurate impression. So in step 1, your accuracy goes down. So that's why, as per the head and neck oncologist and the other prosthetics team that we work with, they do not recommend this kind of socket. And when I actually did this patient with them, I also started rethinking our own techniques. So there's a lot to learn across, specialities. So what we thought was ideal all these years traditionally, like using the lid skin, may not be ideal in certain setups. So motility here does not always help. So how do we rehabilitate this situation? Of course, with silicone or exentration prosthesis. These are just in a nutshell the steps where we go through the wax modeling, centration. And another important aspect is skin matching. As you can see in this design, it's not a plain skin color. You can see those red and yellowish dots, which almost imitate as if they are your surface capillaries. Like here, that's actually my own hand that I've kept, and you can see how the granulated appearance of that artificial silicone skin is looking a lot like your own skin. This is the concept of flocking, and this really gives a real life look to the skin instead of a dead or like a doll-like color. So this really helps in enhancing the exentration prosthesis. Apart from that, of course, putting eyelashes in the good technique and taking care of, like I call it, trichological options like the eyebrows and the lashes. Sometimes it's a 80-year-old who comes to us and we try to put in these beautiful Chinese kind of lashes. It doesn't work. It's better to just paint eyelashes instead of trying to put those huge long lashes for those patients. So we have to again try to merge and symmetrize the eye. Another option is this case from UK, where this patient preferred to wear a closed eye prosthesis. So he was very unhappy with his open eye prosthesis, which did not move and the lids did not move, because exentration prosthesis are always straightforward. So here he preferred to use a closed eye prosthesis which looked like a ptotic lid instead of having to have a starry eye. In recent advances, we have 3D photography and surface scanning, where patients undergo pre-op digital imaging. It's also called rapid prototyping. And then after we typically do this in cancer reconstructions, where after the surgery, we'll use the pre-op images to reconstruct their face using prosthesis. Just before the last slide, if you look at this, where do you think, how many seaweeds do we have? This is from an aquarium, and as you can see, there is one seaweed there, and here in the center, what do you think is that? So that's basically a seahorse. It's not a weed. So from nature itself, we can use the concept of wise disguise. So whenever we try to rehabilitate prosthesis patients or patients without eyes, we have to think out of the box and try to disguise their disfigurement so that they have a more acceptable and a better face. To summarize, this is actually the patient that we did in Narayan Netralaya, Bangalore this October with the silicone prosthesis. An ideal socket looks good with prosthesis than without. So it need not look neat at the end of the surgery, but it should definitely be able to take the prosthesis well. Planning ahead helps to optimize outcomes. Sometimes fitting in a prosthesis is not enough, and the concepts of symmetry and wise disguise go a long way in rehabilitating the socket. I'd like to thank my team in Bangalore and thank all the audience.